To say that we do a lot of clinical research, but I take no direct funds from pharma. All conflicts are for institutional payment for research, nothing to me. So I'm going to try to spend maybe about 45 minutes kind of going through this presentation, and going to try to leave ample time at the end for us to have some discussion. But I'm going to be talking about select trials for HER2 positive agents, kind of what I see maybe the current treatment algorithm for HER2 positive disease, adverse events and how I monitor these in clinic, and then a little bit of maybe how things are going to change as we work a little bit more on sequencing and bringing some of our newer agents up into the earlier lines. So I tried to make this Canadian specific slide. So essentially 27,000 people are diagnosed with breast cancer each year in Canada. Very familiar with the 15% that are HER2 positive, but really looking at this last area where the 5-year overall survival rate, if patients have metastatic disease, is really still only 40%. So despite the fact that we're doing better in HER2 positive disease than we are in some of the other counterparts like triple negative, there's still a need to continue to improve. And this slide really just highlights the same. So if we look at the two numbers highlighted in blue, these are the patients that have HER2 positive disease, really, again, just showing that overall survival at 5 years is about 40%. Certainly doing much better than we are for triple negative. So that's a good thing. And one of the reasons that we're here today is really to talk about some of the new agents that have helped us get to that point. So I put this slide together really just to show where we were in 2018, because I find it pretty dramatic, actually, how much things have changed in the HER2 positive landscape in the past 4 years. So in 2018, we had one ADC, we had TDM1, we had 2 antibodies, trastuzumab and pertuzumab, and then we had lapatinib and neratinib as our tyrosine kinase inhibitors. And so the algorithm really was a taxane with trastuzumab and pertuzumab first line, TDM1 second line, and then third line was really wild, wild west. You could either do chemo with trastuzumab, you could do capecitabine with lapatinib, but there was no one standard of care at that point. So let's go through the Cleopatra data just really briefly to kind of talk about, where we got to be using pertuzumab in the first line space. So essentially the addition of pertuzumab here in our blue line, progression-free survival was improved by about 6 months, but in this graph, you actually see overall survival, a 16-month improvement in median overall survival when we added pertuzumab to trastuzumab and docetaxel. So I'm going to kind of follow a patient through the majority of our talk just to kind of show maybe how this plays out in real practice. But this is Nicole. She'll be our friend for the next 45 minutes. She is a young postmenopausal woman, so right at about 55, who went to her primary care doctor because she was having a lot of hip pain. And lo and behold, due to COVID, she hadn't gotten her mammograms, which I think we're all seeing in clinical practice right now. And on exam, she had about a 3-centimeter mass in her right breast and also some palpable axillary adenopathy. This was biopsied. It was ER/PR negative and HER2 3+ on IHC. And systemic staging revealed that she had bone mets to her sternum, as well as that left hip that was causing pain. And she also had supraclavicular adenopathy. So I think we could all agree that first-line therapy we've had around for quite some time. It's taxane with trastuzumab and pertuzumab per the Cleopatra regimen. So Nicole tolerates this pretty well. She has a little bit of neuropathy, some nausea, some fatigue, and does have hair loss from her taxane. But in cycle 6, she just becomes more tired. She's not exercising anymore. She's not going to work full time. And so we discussed with her dropping out the taxane at the point of cycle 7 and continuing her pertuzumab and trastuzumab alone. And she goes on to receive 23 cycles of AI essentially with trastuzumab and pertuzumab, and she tolerates this much better. And I think, we're all quite familiar with that. We tend to kind of maybe treat with chemotherapy till maximal benefit or 6 to 8 cycles, but certainly if people are struggling, we drop the taxane out. So let's move on to Amelia. Amelia was our study that really submitted TDM1 as our second line option. Another maybe oldie at this point, but a goodie. And so on the left, you can see that progression-free survival with TDM1 was about 3 months longer than capecitabine lapatinib. And when we looked in terms of overall survival, again, almost 6 months benefit in overall survival with TDM1 over cape lapatinib. And so this really solidified TDM1 as our second line option. So that kind of covers a little bit of the history. Now let's get on to the newer agents. So trastuzumab deruxtecan. And I'm sure you guys have seen many slides like this, really just emphasizing how an antibody drug conjugate works and what's special about trastuzumab deruxtecan in the fact that it binds, is taken up intracellularly, then the cytotoxic drug is released. And in the case of trastuzumab deruxtecan, it actually can diffuse back across the cell membrane into the extracellular space and affect cells around the target cell that may not have as high a HER2 expression. And so we really call this the bystander effect. And it's probably one of the large reasons too, why we see such good activity in HER2 low with trastuzumab deruxtecan. So what does trastuzumab deruxtecan look like? Its DAR is 8. It has a topoisomerase 1 inhibitor payload that's exatecan derivative, and it has a tumor selective cleavable linker. And you can see in this diagram that the little burgundy circles are payload attached here to a HER2 monoclonal antibody. And so how does it stack up with TDM1? They're both antibody drug conjugates. They're both targeting HER2. And so you can see that TDM1 has a drug to antibody ratio about 3.5 to 1. It doesn't have a tumor selective cleavable linker there, and it doesn't have bystander anti-tumor effect. So despite the fact that they're both HER2-directed antibody drug conjugates, we can see why perhaps trastuzumab deruxtecan behaves a little bit differently than we've traditionally thought of for the antibody drug conjugates. So this was the DESTINY-Breast01 trial. It was our first study here with trastuzumab deruxtecan, and this was a very heavily pretreated patient population. But you can see from this waterfall curve on the left that the overall response rate was over 60%. And if you look at just those patients that didn't have progression, this is upwards of over 95%. So you can almost guarantee patients that when given trastuzumab deruxtecan, that at least the first scan is going to look good. And then the duration of response is actually pretty impressive. So over a year, about 15 months. But on the right, you can see that the one thing that plagued us a little bit was that we saw these fatal cases of ILD pneumonitis. The majority of the about 14% of ILD pneumonitis was grade 1 and grade 2, but we saw 2.2% of patients that had grade 5 or fatal pneumonitis. Based on DESTINY-Breast01 here in the United States, right before Christmas of 2019, we had approval of HER2 positive metastatic disease for patients that had already received 2 prior HER2 directed regimens. And what about the CNS metastases subgroup? And I'm going to differentiate this a little bit from the HER2 CLIMB trial that we talked about later, because the patients that were enrolled with brain metastases onto this trial were what we expected. It was the normal population. It was the patients that had had brain metastases, but were treated and subsequently stable. And there were 24 patients on the study. So we're talking about low numbers here. But you can see that those that had brain metastases in this CNS subgroup really looked like they did no worse than those who didn't. In fact, numerically, their progression-free survival was maybe even just a tad longer, but certainly not statistically significant. So this led to the DESTINY-Breast03 trial, which was our trial really looking at bringing trastuzumab deruxtecan up into the second line space, and was randomized 1-to-1 head-to-head against TDM1 from the Amelia trial. So our second line standard here. And what we saw, as we say in Nashville, Tennessee, this is the curve that you can drive a truck through. A hazard ratio of 0.28, probably just about the best hazard ratio we've seen in breast cancer in quite some time. And you can see over on the left that the response rate upwards of 80% with trastuzumab deruxtecan in the second line space, which only about a third of patients have an objective response for TDM1. Now on the left, you'll notice that we don't have a PFS really outlined here. TDM1 was 6.8 months, but it was not reached by blinded independent central review. Now, investigator review, it's about 25 months. So really, you're talking about a little bit over 6 months compared to a little bit over 2 years. Quite impressive. And graphed out here, just to do the dreaded cross-trial comparison, is our benefits of the other experimental arms in trial, whether that's addition of tucatinib or pertuzumab, et cetera. And you can see that the progression-free survival of trastuzumab deruxtecan is even longer in the second line space than we get out of pertuzumab trastuzumab in the first line. So we'll get to later why that might be significant. So Nicole is essentially on first line therapy for 20 plus cycles. And then she develops 3 new liver lesions. The largest is right at about an inch or 2 centimeters. And she also has some growth of nodes now also in her mediastinum. She has normal liver function from an AST, ALT, bilirubin standpoint, and her oncologist recommends trastuzumab deruxtecan for her. So I've included some Canadian treatment recommendations here. So you can see in the grayed out part at the top of your slide, taxane, trastuzumab, pertuzumab. But when we drop down into the second line, really recommending TDXD, but also the caveat that we do have capecitabine, trastuzumab, and tucatinib recommended here or approved. And so kind of how do we make that decision? I would say that most patients are getting trastuzumab deruxtecan now second line with how profound the benefits are. But tucatinib could be a reasonable consideration, particularly for your patients that really have prominent brain mets as their problem. So what do we know about safety since DESTINY-Breast01? What did we see in DESTINY-Breast03? And essentially grade 3 treatment emergent adverse events between TDXD and TDM1 are actually pretty equal, about 50% either way. There is about double the rate of treatment discontinuation with trastuzumab deruxtecan, so about 14% instead of 7%. And almost fully what accounts for this is that 8% of patients that discontinue trastuzumab deruxtecan due to ILD and pneumonitis. But we can also see on the bottom that the treatment duration is really markedly different. So you're really talking about almost an extra year of therapy for those patients that are on trastuzumab deruxtecan at this data cutoff. And so we looked at something called exposure adjusted incidence rates. So essentially normalizing for how long somebody is on something, instead of just adding up all their adverse events, you would assume that if you look at adverse events over a 3-year period, that it's going to be higher than it would be over a 1-year period, right? So kind of a calculation to normalize this. And the exposure adjusted incidence rates for grade 3 adverse events were actually lower at 0.42 with TDXD compared to 0.7 with TDM1. And when we look at serious adverse events, similarly, actually a little bit lower at 0.17 for TDXD compared to 0.27 with TDM1. So what are our prominent side effects? Prominent side effects really are nausea. I think this is one of the things that sometimes people underestimate, kind of assuming that all the antibody drug conjugates are equal and we don't struggle as much with TDM1 here. But for trastuzumab deruxtecan, nausea is definitely a prominent side effect. So you can see about 3/4 of patients are having some grade nausea. We also can see neutropenia, and I'll also draw your attention to the alopecia line, which isn't highlighted, that about 40% of patients have alopecia. So I think that's also a little bit different than some of the other antibody drug conjugates. And certainly we want to tell our patients that this is a potential, because patients definitely get upset if you don't warn them that they may lose their hair. So what did we see in terms of ILD pneumonitis? I thought this was extremely reassuring. So now with increased monitoring and recommendations around ILD pneumonitis, specifically that grade 2 or higher, you stop the drug. Grade 1, you hold the drug even. So this is asymptomatic, only found on a CT scan type pneumonitis. You're holding drug, seeing if this gets better, and then you can restart within 4 weeks. So with these recommendations, we see no grade 4 or grade 5 ILD pneumonitis any longer. And in fact, less than 1% grade 3. So I think this really gave us a lot of reassurance that we can safely give this. And in fact, it looks safe enough that it's appropriate to move it into earlier lines as well. So based on this, in May of this year, the FDA expanded the approval for after 1 prior HER2 regimen for metastatic disease, or for those patients that quickly relapsed after neoadjuvant adjuvant treatment within 6 months. So let's go back to our friend Nicole. She's now been on trastuzumab deruxtecan for about 8 cycles. She struggled a bit with nausea and vomiting in the first cycle with grade 2. Now with some tweaks to her medication, she's doing much better, grade 1. She also has some fatigue and has some alopecia. And so what do we recommend in terms of antiemetic prophylaxis? So for the top here where it says acute prophylaxis, this is pretty much what we do here in my clinic. We give ondansetron, dexamethasone, as well as an NK1. And so different places have different recommendations. I think in Canada, you guys may use ondansetron, dexamethasone, and maybe olanzapine. But regardless, I think most people are using a 3-drug prophylactic antiemetic regimen and then tailoring from there. There are certainly some of my patients that can go to less, and there are a couple patients that may need a little bit more. So I really love this slide because I think it shows us that we need to pay attention to the nausea for trastuzumab deruxtecan. If you look at TDM1 in blue, you see this little spider web plot showing that nausea happens in about 40% of patients. But if you go over to red, you can clearly visually see now that nausea vomiting is a much more prominent complaint with trastuzumab deruxtecan. And in fact, also for sacituzumab govitecan, one of our other antibody drug conjugates that also has a lot of diarrhea. But so they're not all created equal. And I think that's really where our antiemetic drug recommendations come from. So this is a table just to say this in a little bit different way. Here, they actually recommend dexamethasone with the palonosetron. And then if it's not ideal, adding an NK1 in the second cycle. So various places have a little bit different recommendations. So let's talk a little bit about ILD here, just to kind of get us all on the same page, because not everybody walks around grading ILD per CTCAE criteria. So grade 1 is asymptomatic. And so you say, well, how do you know they have it if they're asymptomatic? So this is really incidentally found on staging scans. And remember, in the trials, we were doing scans about every 6 weeks. And so we had a lot of opportunity to find this. Grade 2 is any symptoms. So that's somebody saying, you know, I'm feeling more short of breath when I'm going up the stairs. You get a CT scan, they have ILD pneumonitis. And grade 3 is severe symptoms or needing oxygen. Okay, that's typically when somebody might be admitted to the hospital. And I'm very aggressive about kind of educating my patients directly about ILD pneumonitis. We've been using this for quite some years. We had all of the clinical trials, but it was always my fear that somebody was going to go to an urgent care or walk-in clinic or go to their primary care doctor and think that somebody had pneumonia or they had bronchitis and give them a steroid pack and some antibiotics, not recognizing that ILD was a prominent side effect of their drug, especially when we realize that when we find these and intervene early, they're doing really well. But if we don't, there's the potential for grade 5 or fatal cases. And so I tell my patients, if you have any shortness of breath, if you have cough, etc., I want to know about it. If you ever end up in an ER or anything like that, let them know that you're on this drug that can cause ILD pneumonitis. And so this is a little bit of a busy slide, but it's just looking at the recommendations for management of ILD. And this is different than we treat ILD pneumonitis for something like immunotherapy, where we really don't make that big of a deal about it until it's grade 3. You can see here for grade 2 or above, we're really recommending permanently discontinuing trastuzumab deruxtecan. And even for grade 1, we're stopping it. In my personal practice, I normally give them a really quick pulse of steroids, rescan them, make sure it's gone, and try to get them restarted. And that's been I've been successful with that in my practice. And then also just outlining dose reductions that we have for trastuzumab deruxtecan. So on the left, you see the ESMO guidelines. On the right, you see NCCN guidelines, really just kind of reiterating that taxane with trastuzumab and pertuzumab for first-line treatment. For second-line treatment, we have trastuzumab deruxtecan. We still have TDM1 that's approved. And we also have Kate-Traz-Dacatinib that can be used in the second-line space as well. So I put this slide in for a little bit of food for thought. And I think, you know, I don't have the perfect answer for this, but I think we're starting to move the bar here a little bit. You know, should we start ordering brain imaging on all patients at time of treatment changes? You know, we now have drugs that work well in the brain. This is potentially something that would influence how we manage the patient. And also a lot of times when we don't look and we wait until somebody has a seizure or a significant complaint, that the brain met can be actually quite large and more difficult to treat. So this is not part of our standard recommendations right now. Honestly, we don't have reimbursement suggestions for this. I would say that I have a very low threshold with any headaches, nausea out of what I would expect, certainly any neurologic symptoms or unsteadiness on their feet, etc., to order brain imaging. But it wouldn't surprise me if over the next couple of years, this becomes more standard, particularly at time of treatment changes. So let's talk a little bit about tucatinib. We had this here in our phase 1 unit since 2013. I very distinctly remember when it was because we put the first patient on trial 2 days before I gave birth to my first daughter. So very easy to remember October 2013. And so what's different about tucatinib? It's a tyrosine kinase inhibitor, but what's special about it is that it's HER2 specific. So unlike neratinib and lapatinib, where they hit both HER1, which is EGFR, and HER2, that's really translating to the side effects you see of the rash and the diarrhea. Tucatinib is HER2 specific, and so we get away with not having a lot of those side effects. So let's talk a little bit about HER2+. This was the registrational trial that tucatinib was approved off of, and you can see patients either received CAPE-Traz or CAPE-Traz tucatinib in a 2-to-1 fashion. And what's boxed here in a red bar, I really want to highlight. This was really incredibly progressive at the time, but it included not only our traditional patients with brain mets that had treated and stable brain mets, but it included even 2 groups that were higher risk, patients that had brain mets that had not been locally treated, and patients that had treatment and subsequently progressed. And so this was a really high risk patient population. And in fact, about 48% of the patients coming onto trial did have one of those 3 categories of brain metastases. And the HER2 trial met all primary and secondary endpoints. We improved progression-free survival, reduced by 46%. We reduced the risk of death by 34%. And when we looked at progression-free survival in patients with brain mets, still quite a big benefit. So when we look at the progression-free survival benefit in brain mets, I like this slide and the next slide, because on the left, you see all patients with brain mets, okay? So the 3 categories. And we improved progression-free survival from 4.2 up to 9.9 months with a hazard ratio of 0.32. But if we look on the right, we're talking about just patients with active brain mets. So those are the patients that have brain mets that are untreated or brain mets that were locally treated and subsequently progressive. So filtering out those patients that just had treated stable brain mets. And here we see we're improving progression-free survival from 4.1 up to 9.5 months. And what about when we look at overall survival? Same schematic. So you're essentially increasing survival in all patients with brain mets from about a year to a year and a half. And when we look at those with active brain mets, numerically, it's even larger, from a little bit less than a year up to almost 21 months. So what side effects do we see with tucatinib? And I'll start here with the burgundy bars. The burgundy bars are capecitabine with trastuzumab. And so essentially what we're looking at are capecitabine effects. So we know that GI toxicities like diarrhea, nausea, vomiting can happen with capecitabine. Hand-foot syndrome, certainly a prominent side effect with capecitabine. Stomatitis, a little bit more rare, LFT abnormalities. And so if you look, for example, at nausea, a little bit of increase with tucatinib and a little bit of increase with diarrhea as well, although they have done an analysis and really the increased diarrhea can pretty much be accounted for increased treatment duration for the patients that were receiving tucatinib, but certainly something that we should caution our patients about. The side effect that I really think tucatinib can contribute to is all the way on the right of the graph, the AST/ALT. And so that's the one side effect where I would think about dose reducing both the tucatinib and the capecitabine if it occurred, the liver function test. But any of these other side effects, fatigue, nausea, diarrhea, hand, foot, all of those, I'm dose reducing the capecitabine and leaving the tucatinib where it is. And so based on the results from HER2 in April of 2020, the FDA approved this in tucatinib in combination with trastuzumab and capecitabine. So I think we're all pretty familiar with how to manage diarrhea, but essentially we start with loperamide, upwards of up to 16 milligrams a day or 8 capsules a day. And if that's not working, we certainly can add Lamodal. And if that's not working, we can go to things like octreotide, et cetera. I can say that I've never had to go up to octreotide for capecitabine, trastuzumab, tucatinib, and the vast majority of patients are managed on loperamide alone. So what about other dose modifications? So we've kind of covered diarrhea, and then I'm not going to read through all of this, but you can see it's pretty well scripted out what to do in terms of liver function tests. For grade 2, you hold until it improves back to grade 1, and you can restart at the same dose. For grade 3, you hold until it resumes back to grade 1, and then you dose reduce. And for grade 4, you shouldn't re-challenge those patients. So let's go back to Nicole. If you remember, she was on trastuzumab deruxtecan, and she's now telling us that she has some shortness of breath climbing the stairs after 38 cycles of trastuzumab deruxtecan. So Nicole clearly got some benefit here. And so on imaging, she ends up having radiologic findings consistent with ILD. So she's grade 2 ILD because she's symptomatic and has radiologic findings. So her medical oncologist discontinues trastuzumab deruxtecan. They restaged systemically, and she still has stable disease, so she actually didn't progress. But a brain MRI actually shows 3 new small lesions in her right frontal lobe, consistent with brain metastases. So she actually has local therapy with stereotactic radiosurgery, does pretty well with that, and then starts capecitabine, trastuzumab, and tucatinib. So another one of the dreaded cross-trial comparison slides, really showing the benefit of tucatinib here in the lime orange in this third line space, and other agents that we used to use like TDM1, et cetera, although we still potentially could use it third line now, chemo margetuximab, et cetera, and just chemo with trastuzumab, which we often go back to once we've exhausted some of our other agents. So where does the Canadian treatment recommendation sit? Kind of exactly with what we've been doing with Nicole. Trastuzumab, taxane, pertuzumab up front. Consider trastuzumab deruxtecan or Kate tucatinib second line. Then we certainly have TDM1, as well as other chemo and trastuzumab or other capecitabine combos here. So this is a little bit of a busy slide just to talk about CNS disease. So traditionally, we thought of the antibody drug conjugates as not really getting into the CNS. They're big, bulky molecules, and they don't diffuse across the blood-brain barrier well. What we're realizing is that patients with CNS metastases don't have a very good blood-brain barrier, and certainly if they've had any local treatment like surgery or radiation. So despite the fact that you would think that TDM1 and trastuzumab deruxtecan shouldn't get into the brain very well, we have a good body of literature that patients with brain metastases that have had objective responses with TDM1. And we're certainly getting more literature now that with trastuzumab deruxtecan, this is even more marked. But on the top of the slide, you can see our tyrosine kinase inhibitors, and certainly the fact that they do cross into the blood-brain barrier. Tucatinib actually a little bit better than neratinib and lepad. So let's revisit this brain met data. This is a little bit of a different version of what we've already seen on one of the other slides. But really, you can see that if you're looking at the 2-year mark, et cetera, overall survival is over double for patients that receive tucatinib. And those with treated stable brain metastases, overall survival is still improved. And in fact, remember on HER2+, overall survival was improved in all comers, not just those with active brain metastases. So what did we see in terms of DESTINY-Breast03? Now, remember that the patients that had brain metastases were only about 20 patients, so 24 to be exact. This was a smaller population. And remember that nobody coming onto this trial had active brain mets. They were all treated and stable. But again, progression-free survival still looking much better with a hazard ratio of 0.25 with trastuzumab deruxtecan. And in fact, I think this is actually really impressive. The intracranial response rate with trastuzumab deruxtecan is much better than TDM1, but even just the responses themselves for a big bulky molecule is really showing us that we're getting good activity in the brain. About a quarter of patients receiving a complete response in the brain, and about a third of patients receiving a partial response. So again, this just kind of shows this in the same way. So to not be completely negligent, we'll just touch on NALA here very quickly. So this is neratinib. It's a pan-tyrosine kinase inhibitor. and it was given in combination with CAPE, and the control arm was CAPE with lapatinib. So you can see a little over 2 months improvement in progression-free survival with neratinib and CAPE over lapatinib and CAPE, and about a 2-month benefit in overall survival. So a significant statistically benefit, maybe a little bit smaller in magnitude, but it comes with a cost because neratinib diarrhea can be more challenging than the diarrhea with some of these other agents. And in fact, you can see here, the vast majority of patients with capecitabine neratinib are going to have some diarrhea. Now, if we look compared to grade 3, grade 4 for CAPE lapatinib versus CAPE neratinib, you can see almost a doubling in severe diarrhea, with essentially a quarter of patients having grade 3 or grade 4 diarrhea with CAPE neratinib. So how do we manage this? So this is a control study, and I think this is actually brilliant. Sometimes the simple things are the answers, right? So they start for week 1 at just 3 tablets. At week 2, you go to 4 tablets. And at weeks 3, you go up to full dose 6 tablets a day for your 240 milligrams of neratinib. And, the question always with these escalations is, well, if somebody's having a little bit of diarrhea, are you going to escalate? How many people actually get to the dose you're supposed to get to? And so actually 93% of patients escalated to the full dose. So pretty impressive. And that was a very effective way to control diarrhea. So this is really looking at extenet versus control and some of the other ways to manage diarrhea: loperamide with budesonide, cholestyramine from our GI colleagues with loperamide. And there's certainly a variety of ways you can manage this with either drug or escalation. I typically use the control regimen with escalating the neratinib and making sure that patients have loperamide at home. And they typically do pretty well with that. So where do we stand? So compared to 2018, there's actually been a lot of progress in the past 4 years. We had in 2019 the approval of adjuvant TDM1 percatherine. We got TDXD for metastatic disease in 2019 that was then bumped up to second line in 2022. In 2020, we had neratinib for metastatic disease as well as tucatinib, and also margetuximab, a new antibody. So this is how our slide changes now. We have 2 antibody drug conjugates, we have 3 antibodies, and we have 3 tyrosine kinase inhibitors. So a lot of progress in just 4 years in terms of drug development. So where does my current treatment algorithm sit? So right now, taxane, trastuzumab, pertuzumab is still standard first line. Second line, vast majority of my patients are receiving TDXD. It could be appropriate for patients with really low burden of disease, bone only, older patients, etc., to maybe still use TDM1. You could also use CAPE tras tucatinib for patients with active brain mets. But then typically third line, we're thinking CAPE tras tucatinib. And then fourth line, we can go back to TDM1. We can go to chemo with margetuximab. We have capecitabine combos, and certainly we have clinical trials. So in fact, there was a Canadian-based paper published just this year talking about kind of treatment sequencing for metastatic HER2-positive disease, also encouraging all of the great clinical trials that you guys have there as well. But certainly, I think this is the trick, is we've got a lot of agents now, and as some of these agents go up into even earlier lines, it shuffles our ordering a little bit. So this is the complete build out summary. Taxane, trastuzumab, pertuzumab first line, second line for most patients, trastuzumab, deruxtecan, third line, probably for most patients, CAPE tras tucatinib, fourth line, maybe back to TDM1, maybe back to chemo antibody combos. You could also think about other capecitabine combos. So definitely gets a little bit hairier towards the end of this, but it's benefiting from riches. We have a lot of options. So what's next? What's coming? So there are a lot of trials with tucatinib and trastuzumab deruxtecan coming. We have DESTINY-Breast07, which are TDXD combos. And by combos, I mean TDXD with endocrine therapy, TDXD with an AKT inhibitor, TDXD with chemo, like capecitabine or a taxane. DESTINY-Breast09 is a more traditional first-line trial. It's TDXD versus taxane, trastuzumab, pertuzumab, even with a third arm that's TDXD with pertuzumab. So kind of a head-to-head challenge of TDXD versus THP. And then Destiny Breast 12 is looking at TDXD really around brain metastases population, with a little bit more liberal inclusion for some of those patients with higher risk brain metastases. HER2+MBC is both popular people at the party in one regimen, TDXD plus tucatinib, and that's for third line and beyond. And then HER2+MBC, I think, is a really interesting design. I like this trial a lot. So essentially, when you give taxane, trastuzumab, and pertuzumab, and then you're going to drop the taxane out, and you would go on to just doing HP alone or HP plus endocrine therapy if the patient has ER positivity. It's looking at adding tucatinib at that point once the taxane drops out. And so I think an ounce of prevention is probably worth a pound of cure. And so I'm very intrigued to see whether putting tucatinib here earlier, whether we might have any influence on future brain metastases. Together is actually looking at tucatinib with immunotherapy, and then a variety of other options, gemcitabine or vinorelbine, et cetera, with tucatinib, really kind of seeing about other partners other than capecitabine. So in summary, trastuzumab deruxtecan is continuing to move earlier in the treatment of HER2-positive cancers. I don't think any of us probably have a whole lot of doubt that we aren't going to have a positive trial in the first line, and we're probably going to have positive trials in the neoadjuvant and the adjuvant space. So for our patients that don't present with de novo disease, we're potentially going to be using trastuzumab deruxtecan in the early setting, which then kind of goes back to shifting our treatment algorithm for those patients that relapse quickly and end up with metastatic disease. Certainly, brain mets continue to be a very large problem for our patients with metastatic HER2-positive disease, with really almost half of our patients having to face brain metastases at some point in their course. I don't know about you guys, but it seems like the better we do systemically, the more the brain mets actually become a problem. I recently had somebody that had a pathologic complete response to neoadjuvant TCHP, and 2 treatments away from being done with trastuzumab and pertuzumab in the adjuvant setting, she presented with brain mets. All she has, no disease anywhere else. She was a pathologic complete response patient, but now she has brain mets. So certainly that's something we have to keep track of and try to do better at. And then there certainly are new agents coming, and those are in the flavor of antibodies, bispecifics, where maybe you look like trastuzumab on one side of the molecule and you look like pertuzumab on the other, or even a novel binding site. We've got many new antibody drug conjugates in development. I've got several of them in my phase 1 unit right now. New tyrosine kinase inhibitors, and then also immune-based strategies. And these come in a few different flavors. You can have more of a bispecific type molecule where you have a trastuzumab on one side and a CD3 or PD-L1 on the other. We have HER2 sting, et cetera, in clinical trials. So I definitely remain very excited about those as well. Okay, so I think I've left us plenty of time to go over and do some questions or any discussion.
Thank you so much, Dr. Hamilton, for that excellent and thorough presentation. Let's